And the first few slides aren't really that interesting, so I'm just going to, in the interest of time, I'll just
go now. Yeah, go.
It's the intro slide that basically says, just reminding everyone, I'll be starting us off with a very brief introduction to implementation science. And you know, I'll delay on the substantive content in case there are a bunch of participants hoping to join, but
yeah,
say that my hope for that brief 15-minute introduction is that I would basically, you know, briefly address 3 questions. On the second slide, John, you can just go straight to it. And that is, what is implementation science and why should we care? And also, how can implementation science advance climate health adaptation? So on the next slide, I just want to start with definitions to distinguish implementation science from the practice of implementation. So implementation practice is the use of evidence or interventions, policies, practices, tools, whatever that evidence is. Whereas implementation science is the study of the use of those interventions and evidence. And so there have been a few nuanced ways the field has defined itself, but essentially implementation science is defined as the study of methods to promote uptake of evidence-based practices or interventions in a variety of settings. So on the next slide, in terms of why, so I don't think we have to look beyond this very moment to recognize why implementation science could matter. So just taking our everyday lives for the past year, yeah, exactly 1 year, and specifically looking back to the end of 2020 with the promise of not just 1, but 2 highly effective vaccines, and now 3 and 4, depending on where you are. And actually 6 and 7, and more than that if you're in Cuba or China or India. But in any case, here in the US, it was a rare moment of hope when these 2 vaccines came out, and a turning point in the pandemic, so we thought. But on the next slide, you can see we all know what happened next. Here in the US, the rollout has been slow and complicated, anxiety growing, shots are slow to reach arms as those final steps of ensuring the vaccines are delivered were left to beleaguered states. So on the next slide, I wanted to highlight this article from the Washington Post from Ashish Jha, who's now Dean of the Brown University School of Public Health and probably no stranger to anyone who has been listening to the news over the past many months about the pandemic. He nicely articulated this problem in the US, which was that at that time, the federal government saw their role as getting vaccines to the states without considering what supports states would need to get vaccines to the people. And this type of problem is not unique to COVID-19. So on the next slide, you can see that the promise of any effective innovation that our science delivers can only be fully realized through its use by a range of stakeholders. So how do we do that most effectively? Is it A, not thinking about implementation and not having a plan? Is it B, thinking about implementation and having a plan informed by intuition? Or is it C, thinking about implementation and having a plan informed by empirical evidence, which is the basis for the science of implementation? So John had mentioned on the next slide this study that, so he gave away the punchline, but I'm just going to briefly walk through what this that study was. So the study, this slide illustrates what happens if we don't focus on implementation, and it displays findings from that study John referenced, which was from 2000 by Andrew Bayless and Sue Boren. And they asked the question, let's assume that the end product of our research is a high impact publication and we don't think about implementation beyond that. What happens next? So what you see in the middle of the slide is the rough publication pathway from publication of our original research to implementation, which they defined as 50% uptake. On the left side, you see all the ways we lose valuable evidence, and the right side estimates how long it takes to get through each of these steps. And on the next slide, you can see the conclusion, which was that, like John said, it takes 17 years for only 14% of original research to benefit patients. It shouldn't be the case that so little takes so long, and that's the time to reach just half of the people who could benefit. So while their study was focused on clinical research, this problem is pervasive across multiple sectors, and so we need to do a better job as a research community. So on the next slide, as you saw with the COVID-19 vaccine example, the problem goes beyond the strength of the evidence for effectiveness. An intervention or program or policy is going to be only as good as how and whether it is adopted by different systems within different communities. But not just that we also have a way to identify those practitioners who could then be trained to deliver the intervention. But we can't stop there. We have a history of training people where there isn't a way for them to come back from that training and incorporate what they learn into their daily lives or practice. So we need to make sure we also consider the needed supports to ensure appropriate use or delivery. But not just that, we need to make sure that we can actually reach all those people who could potentially benefit from it. So on the next slide, you can see that even if we get halfway there at each of these steps, not accounting for issues with access, adherence, dosage, and maintenance, we're still down to just a fraction of the benefit we thought we were going to have with that promising intervention. So again, we need to make sure that we don't assume these steps are going to happen by themselves. Putting it another way, thank you, and this comes from the RE-AIM framework, which is very popular in this field. It's not just effectiveness, but these other dimensions that determine the ultimate impact of our work. How do we develop organizational support to deliver the intervention? How do we ensure the intervention is properly delivered and can be maintained over time beyond the scope of a study? And how can we ensure it reaches everyone who could benefit? So these are some of the research objectives of the field of implementation science. So on the next slide, returning to definitions, I wanted to highlight how we use these terms, and this comes from a trans NIH funding opportunity with NIEHS and 22 institute centers and offices across the NIH. We see implementation science as bridging the gap between research and practice and policy by building a knowledge base on how evidence can be most effectively communicated and integrated into practice. So for the purposes of our funding announcements, which I'll mention in a few slides, we break it down into two different components. Dissemination research is the study of the targeted distribution of information and how best to spread or sustain knowledge and evidence, whereas implementation research is focused on what strategies can best facilitate the adoption and integration of evidence into a given practice. So on the next slide, looking at dissemination research a bit more, the goal of dissemination research is to understand how, when, by whom, and under what circumstances evidence spreads, focusing on all the stages of evidence from its creation to its reception. And these are important steps that we often jump over. In implementation research, on the next slide, we try to draw a contrast from what we see in typical effectiveness studies, which tend to focus on the what intervention can improve outcomes. Most studies assume that if we focus on the what, we will get the answers that we need. What do we need to do for these individuals to improve a range of outcomes? But we jump over this important middle, and on the next slide, you can see that that's the question of how. The implementation strategies that will support the ability of those interventions to be delivered in a whole variety of settings. And importantly, how do we know those strategies are working? We also need to focus on the implementation outcomes. So if we get implementation right, we should see that our strategies support the feasibility of our interventions, that they ensure they are delivered with fidelity, are acceptable to populations using them, and can be sustained over time with high rates of uptake, and that we are understanding the costs. So when we start to focus more on implementation science, what we are ideally seeing beyond effectiveness is that we can have an influence on implementation outcomes, which helps to ensure our interventions have the intended benefits. And understanding these strategies and what works can help to inform future implementation efforts beyond the scope of a single study. So going back to the vaccine example, the hope is that we can build the knowledge base and have empirically formed implementation plans. And on the next slide, I just want to clarify what we mean by implementation strategies. These are the strategies that we use to ensure or enhance the adoption, implementation, and sustainability of an intervention. So these include things like strategies to educate or train people to effectively adopt and deliver an intervention, as well as strategies to ensure those people can incorporate the intervention into their routines or integrate them into their community settings, as well as strategies to support fidelity and inform how to most effectively adapt interventions and implementation efforts to fit within a given context. So how would you select those strategies? It will depend on what barriers you're trying to overcome, what resources you're able to leverage, and who are your stakeholders. On the next slide, you can see that in implementation science, we recognize the importance of context and the multiple levels of context that can influence our ability to deliver effective interventions. Moving beyond the individual or household, we need to consider all the levels in which that individual or household exists and how those different levels can affect implementation. I'm sure this is not new to anybody in this talk with a focus on climate change. But when we've historically ignored these levels, we leave out populations who don't have as good access to services. So how do we best get organizational change? How do we best get communities and states to support the implementation of these interventions? The next slide highlights the importance of engaging critical stakeholders and building the evidence base to support implementation at each of these levels. So on the next slide, I briefly just mentioned that since 2006, NIH has been funding implementation science through a set of trans-NIH funding opportunities. And like I mentioned, 22 of our institute centers and offices are currently signed on. And to date, we've funded, I think, over 300 grants. The purpose of these funding opportunities are to support innovative approaches to developing and testing strategies to overcome barriers to the adoption, integration, scale up, and sustainability of evidence-based interventions, tools, policies, programs, technologies, etc. Conversely, there's a benefit to understanding circumstances that create a need to de-implement things that are ineffective, unproven, low value, or harmful. So I encourage you to take a look at the announcements, but on the next slide, you can see there are questions around all the various aspects of dissemination and implementation processes. So including a focus on understanding how we can most effectively adapt interventions to fit within a given context, keeping in mind that the context is ever changing. We also seek studies that focus on understanding which strategies work best and how they work, as well as how to effectively sustain and scale practices, and also how to de-implement practices that are harmful or wasteful. So on the next slide, I want to couch it in an example of an effort to reduce household air pollution, and specifically on the next slide, studying the implementation of clean cookstove technologies alongside efforts to replace or de-implement the use of practices that generate household air pollution. So NIH has supported, on the next slide, you can see some examples from a trans-NIH effort in the called the Clean Cookstoves Implementation Science Network, with which John, Lindsay, and I are a part of, as are others, many others, led by Fogarty International Center. And this is to tackle some of these issues. So here you can see a few of the studies we've funded that focused on studying how to most effectively support the adoption and appropriate use of clean cooking technologies, while also de-implementing the use of stacking with traditional stoves. And I won't go through these in the interest of time, but I do just want to highlight, if on the next slide, John, let's just say you're still in the process of developing an effective intervention, which may be the case for some of our attendees. So if you're still in the process of developing an effective intervention program or policy, or perhaps testing the effectiveness of an adapted intervention program or policy, how might you consider implementation science earlier on? So here you can see an example of a translational research pathway from intervention development to studying implementation. If you're earlier in this continuum than that purple circle of doing the dissemination implementation studies, you could be thinking about how to design your study to make it more likely that the ultimate findings from your efforts will be implemented. And then on the next slide, you can see one way, some ways you can think about doing that is by incorporating research aims around implementation within our intervention studies directly. So we can be thinking about who will deliver and receive the intervention or practice or technology, and build in tests of the implementation strategies to see whether they can enable those things to be used in practice. Will those strategies enhance those implementation outcomes of adoption, implementation, and sustainment? So on the next slide, I just wanted to highlight that rather than leaving it to chance, we can design our interventions, practices, and technologies with implementation in mind. So going back to the clean cooking example, as you are developing an innovation, you also can be considering how people might be likely to use it based on their current practices. And you can consider what supports might be needed to ensure that people are able to use it, considering all those levels that might influence those decisions and abilities like distribution and supply. So finally, I wanted to conclude with some success stories. And I won't go through the individual stories here, but wanted to highlight that in this recently published paper, 5 success stories were described where studying implementation has advanced the implementation of evidence-based practices. And across these 5 examples, there were several common elements, including developing a shared agenda among researchers and multiple types of stakeholders, using a conceptual framework to guide implementation processes, evaluating the implementation process to make the business case, so that really gets at understanding the costs, empowering operational experts or implementers or practitioners to deploy interventions to existing providers, so considering those supports that would be needed, and enabling and guiding adaptations to the intervention to promote end user acceptance. So really considering the need for adapting interventions to fit within the context. And finally, building capacity for enterprise-wide implementation or quality improvement. So I hope I have been able to convey to you a primer. If you have any follow-up questions or would like information, please feel free to email me. Thanks so much for your time, and I'm eager to hear from our colleagues at the WHO and PAHO, Elena and Daniel.
So thanks so much. I will then just share the screen to present from WHO and PAHO. Thanks again for inviting us to be part of this important event. I just hope, yeah.
It's looking good, perfect.
Thanks, John. So basically, I will go directly to the presentation, and in terms of keeping it short, I think we will both aim to be as fast as possible with any of our slides. Basically, this is just summarizing the key work we are promoting in WHO with regards to public health responses to climate change. So basically, we are not only working with countries to understand which are the health risks or impacts posed by climate variability and change, although this has been the area of work that we've been, let's say, more focusing on with all the work we are doing on adaptation and resilience health systems. But also we are realizing now that we have to be more vocal on the work that we are doing on assessing and promoting health co-benefits of mitigation action in other sectors. So basically, all the work that we do is basically structured around 3 key areas of work. One is health system resilience, another one is health co-benefits, and the third one that is also coming more and more prominently now is healthcare facilities, both greening and resilience. This is just a summary of the projects on climate change and health that we are aware of an average budget around 1 million, the minimum is 500,000. And as you can see, basically WHO is mostly involved in, well, in most of them with experts like Chris Ibai and others that are kindly helping us to make sure that capacity is strengthened at country level for the different things we are doing. This area of work has exponentially increased since I joined WHO in 11 years ago, 12 years ago. Because at the beginning, when I just joined, there was only a project implemented in Europe. And then we were quite successful in getting support from different donors and partners. This is also reflecting on the importance that health is getting in climate change and in climate change policies at country level. Basically, this is summarizing the importance given by countries in their NDCs, nationally determined contributions to health. So all of the blue countries basically include health within their NDCs, no mention in the red ones, and then the gray ones are either no parties or they didn't submit any NDC. Unfortunately, even if the nationally determined contribution is a policy in which countries are basically reporting and committing in reducing their emissions, there is also, of course, a great interest in countries to also acknowledge the importance of adaptation. So most of the mentions to health really relate to adaptation rather than to assessing and maximizing health co-benefits in interventions, mitigation interventions in other sectors. This is just the way we are structuring all our approach to supporting countries to either tackling the health impacts from climate change and building resilience or working on co-benefits. And again, also this is applicable to the work that we are promoting on healthcare facilities. So as you can see, these are basically the steps of a risk assessment and management approach. And either we support countries to do everything. So when we have enough funds and support from a specific donor, basically we help with assessing, for example, conducting a VNA, then developing health components of national adaptation plans, and then also funding. And this is the theoretical approach to building climate resilient health systems that we develop thanks to the support that we provided to countries. This is basically the WHO operational framework for building climate resilient health systems, which provides 10 components to be implemented around the 6 building blocks of health systems. So, which are summarized in the middle. You have health information systems, technologies and infrastructure, service delivery, financing, leadership and governance, and health workforce. So around those, we have these 10 components that we are basically supporting countries with just to make sure that they advance towards climate resilient health systems. In this operational framework, we have specific activities, example of activities that countries could implement under each of those components. And something that is coming very prominently in all countries when either developing project proposals or implementing new interventions is basically surveillance and making sure that they integrate climate and weather considerations within their health surveillance systems. Vulnerability and adaptation assessments, development of HNAPs, and also making sure that all the information gathered fits into the way service delivery is provided. And also healthcare facilities. Something also that we are trying to also maximize is the support that we are providing to countries to develop funding opportunities, basically. And I think colleagues in PAHO can also provide further information on that. This is just a final slide from my side, connecting policy and things that are happening in terms of advocacy at country level. I'm sure that you are aware of this commitment from the UK NHS about delivering a net zero national health service and their commitment to become carbon neutral by 2030. The manifesto for a healthy recovery from COVID, green and healthy recovery, that was developed by WHO and that has been promoted and adopted by different partners. Then there is also all this great movement that Greta is also leading, that basically just makes that youth are asking for more climate action, and health has been adopted also as a key argument there. And then just in the run-up to COP, I just wanted to say that we've been working closely with the UK, and they've included an initiative on health. So health is going to be a key priority for the UK also in the run-up to COP and in COP. And then there will also be a conference on climate change and health, and then additional events on health. So with this, I just hand over to my colleague Daniel for him to continue from the PAHO perspective.
Thank you, Elena. Thanks a lot, John, and thanks for the initial words. I think I'll tweak a little bit my intervention. I don't know if you can see me. I'll tweak my intervention a little bit to react to some of the very interesting things that Gila has raised. And I think that we are occupying a space where, in order to build the bridges between academia and decision-making processes, and as WHO and PAHO rely on this kind of a limbo space of trying to build those bridges and translate the research into norms and regulations, policies, programs, and plannings, even the and interventions like Elena was mentioning at different levels, right? At global, regional, national, subnational, local levels. And it's an interesting space to be where we try to learn from projects like the ideas that Gila was presenting on how to measure and assess interventions and activities, and then trying to scale up from projects to build larger national commitments that will in its turn revert back to action at the subnational and local levels. So it's amazing to see how these feedback loops can work, and being in that space is a very challenging one, but I think that it's an important space to be located. So with that in mind, the climate hazards in the Americas, they vary a lot. Probably most of these topics that I'm showing you in this slide, they affect countries in more or lesser amount. But as a general picture, we can say that countries in the Americas, and we are located in Washington, D.C., and we do work with the 35 countries of the Americas and 18 territories in this region. Heat waves and wildfires in the North American region, but also in the south, in the southern cone of South America, drought, water, and food insecurity in Central America. We have the dry corridor of 6 countries there. Altered patterns of precipitation and landslides. We had examples a few years ago in the Pacific zone of South America, outbreaks of vector-borne diseases like Zika, Chikungunya in South America a few years ago. Hurricanes and storm surges that happen every year in the Caribbean region, but also in North America and Central America, and other topics related with waterborne diseases and toxic biota that are being exacerbated by climate change, severe storms, air pollution, and sea level rise that affects not only the islands, the small island developing states, but also coastal zones. So can we go to the next one, please, Elena? Can I go to the... If you cannot change, I can try to share my screen. Otherwise, I can continue to just present some ideas and we can try to pass the slides later. Let me see if I can share.
I got frozen. If you can just
yeah,
to just make it work.
I can see where. Anyways, I can continue and we can share the presentation later with colleagues if that's okay. Oh, I can try now. No, it doesn't allow me to. Okay, I'll continue and we can catch up with the slides, Elena, if you can. So with that in mind, we've been working not only with governments, but also with civil society, and yeah, perfect. and with regional level and subnational levels. So I'll just go quickly through some of the activities that we've been conducting. Yeah, you can, we are in slide 10 now, please, if you can. Yeah, perfect. No, the next one. Perfect. So we do have, one of the approaches that we are taking is to work directly with governments as part of the United Nations system. That's one of our entry points with countries. So build agreements, considering even multi-country agreements. So we worked with ministers of health and ministers of environment. That was very exciting to see that, you know, I think that intuitively we can think that there's a big connection. I mean, the topics are there, the impacts of climate change on health are clear, but in many cases there are not a very good conjunction of work and collaboration between those sectors. We saw health was quite absent from the discussion in many countries regarding to climate change. So one of the initial challenges that we had was to build those governance structures, those institutional structures that can engage health in them. So having inter-ministerial committees on climate change, including health, was a challenge on its own. And then we built with ministers of health and ministers of environment or climate change from countries, a Caribbean action plan on health and climate change, an Andean plan of action on health and climate change, a Southern Cone agreement of all countries in Central America, and similar things with Central America to build us the roadmaps for interventions, policies, norms, and regulations with regards to this topic on climate change and health, having the high-level agreement on those topics. So next one, please. Yeah, thanks. So one example of activities that we do really enjoy and we need the support from academia, and I think that the audience here from the consortium of universities is a great way of passing this message along, is to build those country profiles that they work as good initial vulnerability and adaptation assessments for countries with regards to health and climate change. So we finalized recently 10 country profiles from the Americas. We are working hard with ministers of health and ministers of environment and institutes of meteorology on that. So if you can continue and pass the next one, is just to show you a few pages of the country profiles. We have the link on the left-hand side. You can access them. And then we can have a good overview of what's in these country profiles that will provide countries some guidance on where they are with regards to their capacities and their needs. We build that with countries. And with that, we have an overview of the country's needs, demands, and where they are within the health and climate change process. Can you continue, please? Yeah, so next one and next one. Great. Another product that I think that will interest you is this Climate Change for Health Professionals, a pocket book. So it's a document prepared for clinicians and other people who are medical professionals or interested people who are in the front lines of working with health and climate change. So can you please give a few extra clicks so we can see some of the pages. We do have for every medical specialty and some recommendations on what to do and not to do, for example, during a heat wave, which medicines not to prescribe. No, that's fine, that's fine. I just wanted to give a quick overview on some products that might interest this audience. And in order to start to close this presentation, as Elena mentioned, we have some other opportunities and working with surveillance systems and trying to build like integrated surveillance systems with ministers of health, ministers of environment, meteorological institutions, and social demographic information. Well, something that we are calling like observatories on climate and health, where we can try to start building the risk models with these integrated databases and then doing the early warning systems for example, for heat waves, we are working with Argentina on this, for respiratory infections in Cuba, and in vector-borne disease, climate-sensitive vector-borne diseases in South and Central America on this. So we do have a lot of work going on these areas with ministries of health, with ministries of environment as a intersectoral space. Next one, please. And the health co-benefits piece, which is crucial. So understanding what are the connections on prevention and health promotion, and creating tools for decision-making, not only at the national level, but also at the local level. So we do have, yeah, can I pass the next one, please? Thank you. So the Breathe Life campaign, so we have a lot of information about air quality and climate change, so greenhouse gas emissions connected with short-lived climate pollutants, how that affects cities, but also at the national level, and how does health can play a role, important role in reducing as well emissions from climate change, from greenhouse gases. Next one, please. Next one. We have tools on GIS-based interventions in cities, so we can estimate the health co-benefits of changes in land use, for example, on green spaces. And my last one, the park prescription program, which is part of this initiative on green spaces. And my last one is the health economic assessment for walking and cycling. So can you give another click? Yeah. So then we can measure the health co-benefits of physical activities, air pollution, transit and traffic accidents, and carbon emissions. And with those tools, we can help local level policymakers to prepare their interventions and measure the health co-benefits associated with that. So now I think that the last one is just our emails. If you are interested, please reach out to us and we'll be glad to continue this discussion. So now I think that we go straight to Chris Ebai that can continue our session. Thank you very much, John, once again.
Morning, good afternoon, and good evening, everybody. Excellent presentations. Appreciate very much the opportunity to talk with you a little bit more about the intersection of adaptation and implementation science. And I want to start with an important framing perspective when we think about the health risks of a changing climate and the kinds of responses we're going to implement to address those. Risks arise from the intersection of three major variables. One are the hazards created by a changing climate, and you've heard about that. A second, as you've heard, particularly in the last presentations from Elena and from Danielle, are on the exposure. And the third set is the underlying vulnerability of regions and populations, where vulnerability includes both susceptibility and includes the kinds of actions you've heard from Danielle that are being taken in many countries to try and address these risks. So when we think about implementation, we have to come from more than the perspective of just a changing climate, but also deeply understand exposures and vulnerabilities in a location. The process that's being used throughout countries is to conduct vulnerability, capacity, and adaptation assessments. This is a quick summary of what these assessments look like in terms of the process. And the result of looking across the vulnerability, capacity, and adaptation assessments that have been conducted is to come up with adaptation measures that are recommended to whomever commissioned this, typically the Ministry of Health, but sometimes the climate change team within a country. And so this is just a synthesis of high priority health adaptation measures. So we have a lot of measures that are being implemented. Many of them are building on measures that already exist within a country. All the health risks of a changing climate are current problems. And so we're typically building on something that's already there. We're taking an early warning system, we're taking activities ongoing in terms of WASH, and looking at how to modify them to make sure that they are going to be resilient in a changing climate. There's lots of ways that adaptation and implementation science are very similar. there are some ways that they are different. And I'm taking this from a publication in December from Chris Boyer and others, looking at ways to leverage implementation science to promote health system adaptation. And you can see three main points on the slide: that we need to help stakeholders navigate the complexities of this space. We need to understand what works well, why it works well, while taking into consideration a changing climate. And I'll spend the next few minutes talking about that. We need to close, as Danielle and Elena talked about, the research gap between research and practice, so that we can start scaling up best practices and lessons learned. And do this in a co-design process so that we make sure we take into account the considerations of the local context, what makes something easier or harder in a particular location. As part of that, looking at organizational readiness assessments would be quite helpful. And of course, we need to support monitoring, learning, and evaluation, and build those much more strongly into the adaptation that we are doing, in the sense not just of monitoring evaluation of a particular project, but thinking in the longer range of supporting monitoring evaluation in the context of resilience and sustainability. Some of the challenges from applying implementation science to particularly climate change adaptation is, although you heard about all the health risks of a changing climate, they don't happen one at a time, they're happening all at once. This is from Pacific Island countries. There were a series of vulnerability and adaptation assessments several years ago. I'm not going through the details. You can just look at this visually and see that for many of these countries, all of these issues are happening at the same time. And so we need to think about interventions that rise above the level of a particular health outcome, and really think about the systems within which these health outcomes occur and how we can make interventions that will address multiple endpoints at the same time. When we're thinking about the exposure, this is from a special report from the Intergovernmental Panel on Climate Change, looking at oceans and the cryosphere. And this is just to show you that the exposures are not constant. Climate change is constant. It is increasing global mean surface temperature, but the consequences in a particular region for different kinds of variables really vary across the regions. And so we need to understand the exposures in a particular location, the rate at which climate is changing in a particular location, the kinds of consequences of that, and not assume that when we do an intervention in a particular location that we can apply it somewhere else where the exposure itself also is different. We're also facing huge uncertainties. We call them deep uncertainties. This is a paper put together for another IPCC special report. This was on warming of 1.5 degrees. And in this modeling work, the author, Sonia Senavaratne, looked across a range of climate projections. And for each projection, took the projection where the world had warmed to 1.5 degrees above pre-industrial. So the level of warming in all of these models is the same. And then queried the models to say, what is the yearly maximum daytime temperature with a 25% chance of occurring a warming of 1.5 degrees? And as you look across these models, on the left-hand side is the lower quartile. So these are the models where there is a 25% chance in the lower quartile of all these models. And you can see, particularly in North America, another half degree of warming is not going to make very much difference. In the upper quartile of the models, you see a very different picture. These are not the extremes, they're just the quartiles. They're equally probable. We know from the report that we could see another half degree of warming by about 2040. We have about 20 years and we could be in either one of these worlds. We really have to take into account deep uncertainty about the rate and the pattern of climate change and what that means for our implementation. We also are seeing fundamental shifts in exposure to climate change and to factors that increase or decrease vulnerability to poverty. Ed Byers did some modeling also for the special report on warming of 1.5 degrees. And as you look across the first row, this is a world in which, in terms of socioeconomic development, we're continuing our current trends. We're moving forward, not at the rate we want to. We do some things well, some things not so well. And the different circles are for warming of 1.5, 2, or 3 degrees above pre-industrial. And you can see, as you would expect, the higher the temperatures, the larger the numbers of people who are both exposed and vulnerable to poverty. The bottom row shows a world that warms to 2 degrees and looks at 3 different socioeconomic pathways. SSP1 is a world in which we're aiming to sustainable development. SSP3 is a world in which the world breaks into large world regions. There's lots of disparities in these regions, lots of inequalities, there's lots of conflict, and you can see very different patterns under the same temperature change. And this is just to emphasize the fact that both temperature and development matter, that our choices for sustainable development are as important as our choices for what we're going to do to try and control the magnitude and pattern of climate by reducing our emissions and by ramping up our implementation of adaptation. And when we think about what this means specifically for health, I'm very happy to say that this was just accepted a few days ago. These are a synthesizing figure that are used in the IPCC reports to say how risk could change with additional temperature change. You can see 6 health outcomes here. The 0 line is pre-industrial temperatures. The Earth is warmed to about 1 degree. And the colors just tell you the level of risk. And so you can see how the colors shift under 3 assumptions about adaptation, and see that, again, this interplay between temperature change and development, and how important it is that we think about both dimensions when we're thinking about adaptation and thinking about implementation. When we look into the future of what it is we're going to be trying to do, this is a very helpful figure looking at resilience and capacity, showing on the green line the quote unquote normal climate. And climate is, as we've heard, resulting in stresses and shocks to our health systems. You can see that after a stress or a shock, you can see a real performance drop. And then the choices that we make will determine whether we transform, recover better than before, or unfortunately, there's possibilities of collapse. So we have to think about this very complex context as we're working on implementation. That implementation is not just about today, it's also about how we're going to be prepared for a very different future. The pathways to get that very different future are varied. There's not one pathway. There's lots of pathways and lots of decision points, as you can see on the left. And on the right, that those decision points will vary themselves over time. That there are a constantly changing complex of situations that, to the best of our abilities, we need to think about. We want to make sure, as we are implementing adaptation measures and policies, that they're giving us more flexible opportunities for the future, again, in a very different climate. Given that complex context, one area that is being advanced in health and in several other areas are conducting stress tests. These are the next steps from conducting vulnerability and adaptation assessments, where taking the change in the climate, changing socioeconomic conditions into account to create tabletop exercises where stakeholders in a particular location can work through some hypothetical situations. What would happen if? And the purpose of doing these stress tests is to understand, given a situation on September 15th in 2035 that is beyond the current capacity of the health system to manage, what you could do today, what you could start today, so that by the time you get to that date in 2035 and you have the massive flooding, you have the extensive heat wave, you have the storm surge, that in fact, the health systems are thinking forward about the kinds of challenges they're going to be facing, in addition to the ones that are already a problem, and making sure that we really increase the capacity of our health systems as we go through and implement various adaptation policies and measures. And so the overall goal is for climate resilience and environmental sustainability, for population health, and for our healthcare facilities. And with that, thank you very much for listening, and I look forward to the questions.
Great. Thank you so much, Chris. And thank you, Elena and Daniel and Gila for 3 outstanding presentations. You've gotten us off to a great start. We are running a little bit late. We're just going to take a couple more minutes and compress our break to 5 minutes so that we'll start up again at 11:10 Central Time, 12:10 Eastern Time. We had a question in the chat that, or the Q&A that Elena has started to answer. I'm going to modify it and open it up, and maybe we'll have time for this one question. And that is, Tamate has asked, how do you incorporate the considerations of equity at the local, at this variety of scales? And each of the presenters has talked about the top-down, bottom-up nature of some of these challenges and solutions, the need for country-level buy-in, but at the same time, the need for appropriate engagement of stakeholders. So if I could ask the speakers, you can all turn on your videos, and we may not have time for everybody to expand on this, but if anybody would like to address, how, your thoughts on either what you've seen or where implementation science could help achieve equitable solutions in the way that we engage the affected populations and other critical stakeholders. I'll stop there.
John, I'm happy to start. When we think about how we conduct vulnerability and adaptation assessments, that's a key component. We need to understand who's most vulnerable, why they're most vulnerable, and what the most effective interventions are to decrease the vulnerability and increase the resilience. So it is central throughout whatever we do in adaptation.
I would just add to that something you actually already said in your talk, Chris, which was this idea of co-design. And I think when implementation scientists talk about stakeholder engagement, I think co-design, user-centered design, this is an example when you're actually designing your studies, designing your interventions with those stakeholders and understanding what strategies are effective. So when we talk about stakeholder engagement, it's not just, I've got this idea, here are stakeholders, let's get you to buy into it. It's really working together with the stakeholders to understand not just what could work, but even what are the problems, and making sure that, as a research community, we're really engaging from the get-go, and it's a collaborative effort.
Daniel, it seemed like you were wanting to join in. Did you have something to add, or?
Well, thanks for giving me the mic. I think that you summarized well, John, some of the presentations. So it's always this balance between the trade-offs between the top-down approaches and bottom-up. And in my experience, a lot of the incorporation of the equity elements and also the most vulnerable populations, right? So we have here in the Americas, especially in Andean countries and Central America, indigenous populations, or populations especially vulnerable to climate change or to some of the climate change outcomes. And when we start working with their territories and engaging them in the process, like Gila said, I think that's the way of maximizing the incorporation of these equity elements and tailored solutions for each very specific context. I think that I acknowledge the importance of having all that incorporated in NDCs, in nationally determined contributions by countries, the commitments and all, but for proper interventions at the that have a greater impact on people, we need to work on bottom-up activities and taking the territories as the main space for interventions and understanding well what are the forces there.
Wonderful. Thank you so much. Great answers. We will, Gila, your finger's up. Did you want to say
Yeah,
something more?
I was just going to add, because I believe folks who are in the session have access to all of the satellite sessions. And yesterday there was a fantastic satellite session, Strategies to Address Global Health Inequities, which I think really gets to some best practices for stakeholder engagement and better words for that. But it was a great summary of these very important issues.
Wonderful. Thank you. With that, we will take our break we're going to compress the break. We're going to take about a 5-minute break. When we come back, we're going to have 6 video case studies that will look at specific projects and discuss some of the implementation challenges. And hopefully we will be able to come back to some of these questions and address issues like equity and how do we structure projects and research embedded in the projects during our final session. So with that, please come back in just about 5 minutes, and you can see the case studies and the wonderful people who have contributed them to our session on the slide. Thanks very much. Welcome back, everybody, to our CUGH Satellite Session 32 on Implementation Science for Climate and Health Adaptation. Sorry for the short break, but we had great content in our first session. We're now moving to our second session, which will be a series of short case study videos, followed by some open discussion with the folks who have made those videos. And so in the interest of time, I see Trisha Castranio, who with the NIEHS, who is coordinating our session, will be our tech lead and set up our videos for us. So welcome back. Each case study will introduce itself, so to speak, as the video, and then we'll open it up to some discussion afterwards. Thank you, Trisha.
Hi, my name is Mike Wimberly, and I'm excited to talk to you today about scaling up malaria early warning to a national level in Ethiopia.
That's good.
Our project is called Epidemia, Epidemic Prognosis Incorporating Disease and Environmental Monitoring for Integrated Assessment. This started as a research project in the Amhara region that was supported by NIH. We developed and piloted a malaria early warning system in the region. Now, with the support of USAID, we are developing a roadmap for national level scale-up. Malaria early warning is necessary to support continued progress in the fight against malaria. Although there have been considerable declines in malaria cases throughout Ethiopia, the burden still remains high in many areas. We've also seen localized resurgences of malaria in recent years. Our understanding of the connections between climate and malaria provides an opportunity to make progress by using climate information to support malaria forecasting. Timely and accurate data are crucial in this endeavor. These data include weekly surveillance data that is collected through Ethiopia's public health emergency management system, as well as free remotely sensed climate data that can be processed and accessed using cloud computing resources. However, to use them effectively, we have to address the challenge of big data. We're dealing with high volumes of data, a variety of data types, and new data that is continually produced at a high velocity. We developed the Epidemia software tools to address these challenges and support malaria forecasting in public health agencies in Ethiopia. In Epidemia, local malaria surveillance data is combined with remotely sensed climate indices acquired through Google Earth Engine. All processing steps are completely automated, and the forecasting results are output as formatted reports. And the whole thing is implemented using the free and open source R language and environment. The reports produced by Epidemia are the means for communicating forecasts to decision makers. There are alert maps that highlight districts where unusually high numbers of malaria cases are predicted. Time series charts for each district provide details about historical trends in malaria and climate, as well as alert thresholds and predictions out to 12 weeks in advance. There are also supplementary maps that highlight recent malaria incidents and climate anomalies. One of the major technical challenges in forecasting is making accurate predictions. So we assess the skill of our forecast by comparing them to naive models that are based on case data alone. This is the same approach that's used to evaluate weather forecasts. So in this example, this is Oromia, the largest region in Ethiopia. We can show that our forecasts are skillful out to 12 weeks in the future. And we can also map the patterns of forecast skill by district. And this allows us to highlight areas where we know the forecasts are working well and other areas where non-climate factors are likely more important. We expect that Ethiopia's National Malaria Elimination Program will be a main user of the forecast and will have a key role in implementation. However, the Ethiopian Public Health Institute has the most capacity to operate the system and connect it to their disease surveillance mission. It will also be necessary to engage with regional health bureaus across all of Ethiopia's regions. So cooperation across multiple agencies will be needed, but will also be very challenging. Another challenge is translating alerts into responses at different levels in the public health system. At the national level, there's a need for long-term predictions to support decisions about commodity purchases. Decisions about distributing these commodities require only about 1 to 3 months of lead time that need to be more geographically precise. Decisions about actual interventions, such as vector control or bed net distribution, require the most spatial precision, but they can be implemented relatively quickly if supplies are available. And finally, there's a need to develop the capacity for sustainable implementation. And this needs to include training in things like programming, data science methods for system operators, as well as guidance on how to use the forecast for decision makers. And we expect, though, that the baseline knowledge that's going to be gained through the training can be extended to a variety of other problems related to climate and health. As I record this, we are in the process of finalizing our roadmap report. As I close, I would like to acknowledge just a few of the people who have worked with us at various stages throughout the project, as well as our funders. If you'd like to know more about the project, please contact me and I'll be happy to talk to you and share more information. Thank you for listening and have a great day.
My name is Limha Bete, and I am the Regional Medical Entomologist for the Pacific Islands Association and Health Officer. The Pacific Islands, including many of the U.S.-affiliated Pacific Islands, are disproportionately affected by climate change and extreme weather patterns. Low-elevation islands, in particular like those found in the 4 states of the Federated States of Micronesia, or FSM, and the Republic of the Marshall Islands, or RMI, have already experienced rising sea levels, persisting drought affecting access to drinking water, and decrease of living space. These climate change paired with transmission of dengue fever in 2019 has pushed health systems beyond capacity. 1,700 dengue cases in Yap State and 3,800 dengue cases in RMI. Currently, addressing dengue fever for the FSM and RMI and for the entire region has only been highly reactive. Speaking at a climate change workshop, RMI's Secretary of Health, Jack Anatol, estimated that the dengue outbreak that began in the early summer of 2019 has cost over $2 million. He said, think of all the things that could have been done with that money had we contained the outbreak. Climate change is not just rising sea level and weather change. It's health, it's disease, and it's impacting people right now. Wilson Matulong was tasked to respond to the dengue cases in Yap State, described that it took over 2 weeks' time to get permissions from traditional village chiefs and to train vector control staff before they could apply pesticides. He said, that's 2 weeks too long. All of these should have been done before the outbreak. we could have prevented the spread in yaks had we had an early warning. With the support from the FSM National and the RMI Health leadership, WHO applied for and was granted funding by the Bureau of Oceans and International Environmental and Scientific Affairs at the U.S. Department of State. We are still building our team to collect and analyze data related to climate, public health, and social demographic variables to pinpoint factors that lead to the spread of disease. The group will conduct place-based predictive models and engage relevant on-island partners for implementation. If successful in the FSM and RMI, WHO will work to replicate predictive models and early warning systems across the USAPI. The project's outcome aims to give each Pacific Island nations lead time of weeks or even months using predictive models to prepare a public health response. This lead time would allow FSM and RMI to train vector staff, reduce mosquito sources, test insecticide resistance, and perform outbreak ready maintenance and procurement. We are aiming to improve coordination within the FSM and RMI health systems and other jurisdictions to keep an eye on the larger regional picture throughout the USAPI. We're also aiming to incorporate climate education in a context where mosquitoes and dengue are not always considered a threat. Due to climate change, many will resort to storing waters in barrels, uncovered cisterns, old fridges, and freezers. These water containers can produce massive numbers of Aedes mosquitoes. Though we just started this project, we have identified some challenges. One challenge that we face in the region is staff availability and high turnover, especially trained ones. In the last outbreak in the Marshalls, our environmental health staff were trained by experts from the NetNews 6, CDC, and PHOA. Environmental health staff were efficient in responding to dengue cases on Ibai and Majuro, but also on the outer islands. They boarded an Okeanos sail canoe, also solar and biodiesel powered, to transport entomological vector control personnel and equipment. The same vector management trainings were provided to environmental health staff on Yap State. Increasing local capacity is part of our strategy, but at the beginning of last year, over 60% of the task force has either left the program to promotion, migration, for better opportunities in the U.S., or have been diverted away from vector management. Due to financial and HR constraints, environmental health departments do not have dedicated mosquito control programs with full-time staffing. Staff are frequently assigned to activities that are considered higher priority, which may limit development and maintenance of an early warning system. How do you implement an early warning system under such settings?
Thank you for joining this case study on the implementation of a malaria early warning system in Peru. My name is Bill Pan, and I'm an associate professor at Duke University. We've been working in Peru since about 2012 on developing and implementing a malaria early warning system, and I can tell you that we've had lots of different challenges. Peru itself has extreme climate variability. There's 3 different ecoregions of Peru, the Amazon, the highlands, and the coast. And what you can see from this output from our early warning system is the fact that if you look east to west along Peru, there is great variability in temperature and rainfall. But not only that, if you look within the Amazon, which are the 3 boxes that are on those the maps, you can see variability that exists even within the Amazon region. And the problem with that is the fact that when you're thinking about developing climate and health priorities, there's a lot of variability in typologies that you have to consider. When the Ministry of Health in 2019 identified 14 priority research areas, unfortunately, none of these priority areas were related to climate or environmental change. If you look through the entire document, you actually only find the word climate or environment twice, once referring to climate change affecting healthcare access, and once in environmental health exposures related to things like lead, mercury, and cadmium exposure. The Ministry of Environment published this report in 2016, which is a comprehensive assessment of climate change impacts on Peruvian livelihoods. across different environments of Peru. This was not written in collaboration with the Ministry of Health, indicating the siloed problem within Peru that exists in other countries as well. But it did have a lot of sections specifically dedicated to the effects of climate change on health. And so this is what the tables look like for each ecoregion. They actually identified the climate change condition, the consequence and the health impact, and even outlined the ICD-10 code that the Ministry of Health could use to classify which diseases would be occurring and link them back to climate change. So this was the coastal region, then they had the highlands, and then they had the Amazon. And what I can tell you across all these three regions that they outlined and discussed, the two primary climate change impacts that were noted were the effect on the increase in zoonotic and vector-borne diseases, as well as diarrheal disease that would spread from flooding. Now, we developed an early warning system that used Earth observations and combined them with data from government surveillance and population at risk. And we created two statistical models to create malaria forecasts. And what we were able to achieve was greater than 90% sensitivity and specificity to predicting malaria outbreaks 12 weeks in advance. We had an implementation plan, which was a partnership with the Ministry of Health and with the Regional Health Directorate, in which we were going to implement the LDAS and the malaria models within the Ministry of Health, which we then modified to implement the LDAS at USFQ in Ecuador and develop the malaria models with Cayetano Heredia in Lima and with CDC Peru in Lima. And then we also were going to be holding stakeholder training. I can tell you that our funding was supported by NASA. They've been very generous with their support in the technological development of this model, but we have struggled immensely with the implementation piece. And part of this is because of the massive political turmoil that has occurred since the beginning of our project. On the left is the list of presidents that have existed since 2012, as well as on your right is a list of the 13 different ministers of health that have been in charge since our project began. I have personally met with at least 3 of these ministers of health to talk about our malaria early warning system, as well as different directors across the health system to convince them the importance and the need to adopt our system. Unfortunately, with each change, it requires all new energy and agreements for us to adopt, or for them to adopt our system. And this has been challenging, and we have deemed this as an unsuccessful and not something that we should continue pursuing. So our main alternative is actually to develop a system where the technological implementation is occurring outside of government, and we create government partnerships for the adoption and scalability. And we actually have recently developed a plan, which we call ASERCAR Malaria Elimination, which stands for, actually, I can tell you if you have a Q&A, you can ask me what the acronym is. But basically, the technological implementation is going to be done at an intergovernment agency called IAI, and the societal adoption is going to be managed by IAI, as well as our Malaria Early Warning System Advisory Team, which will involve and use science diplomacy primarily to partner with national, regional, district, and community level partners. We have developed an entire theory of change in order to test whether or not our implementation strategy is working. I can tell you that we developed this strategy this year. We do not have funding yet to implement and evaluate whether or not this will be successful, but we are still hoping that we get some support internationally. If you are interested in learning more about our early warning system or the implementation of it, please do ask me some questions. Thank you so much. Hello, everyone. Thank you for.
Hello, I'm Rachel Lowe. Thank you for the opportunity to share our work developing an early warning system for dengue in Barbados. So our work in this region began in 2017 on a project funded by the Building Regional Climate Capacity in the Caribbean program. This was led by Dr. Anna Stewart-Ibarra, and we are working with colleagues across the climate and health sectors to understand the perceptions and needs of stakeholders in the region to incorporate climate services into health decision making, and we worked to collect data and curate it and produce risk maps for dengue, chikungunya, and Zika in the island. We conducted stakeholder interviews and provided webinars, training webinars on using climate information for early warning systems. In the Caribbean region, in recent years, we've seen an unprecedented crisis of co-occurring epidemics of dengue, chikungunya, and Zika, with several hundreds of thousands of cases reported. Here we can see the figure on the left shows us the top 10 countries for each arbovirus, and we can see that Barbados is within the top 10 countries reporting dengue. And Barbados is also one of the most water-stressed countries in the world and has experienced severe drought events over the last few decades, which tend to coincide with El Niño events. And with our partners in the Ministry of Health in Barbados, they've begun to recognize a change in dengue epidemiology in the last few years, with outbreaks happening after drought events. So we combined in a probabilistic model the standardized precipitation index using a distributed lag El Niño model. And we found that drought events followed by extremely wet and warm conditions several months later led to the optimum conditions for dengue outbreaks, which is likely due to the way that people were storing water to mitigate the impact of drought, which led to additional breeding sites for the mosquitoes. We compared our climate-driven model to a naive model based on seasonal averages alone and found that our model produced more hits and less false alarms. And we wanted to work to incorporate probabilistic forecasts in the Caribbean Health Climatic Bulletin, which is issued on a quarterly basis. And our goal was to try and strengthen this currently qualitative information with some forecasts that decision makers can use to help target resources. We've recently started a new project with the Red Cross to develop an impact-based forecast methodology for dengue and other arboviruses. And we've started building off our work in Barbados to develop a framework that could potentially be extended to other regions. And here we're combining very simple indicators and interactions of the climate conditions to get a probability of exceeding the threshold. And this information could be presented on a risk map. We're also providing historical forecasts to show how our model would have done at predicting outbreaks. And in an operational framework, we would extract the standardized precipitation index using meteorological station data combined with the minimum temperature data. And for example, if we wanted to produce a probabilistic forecast in August, we would rely on data that had been extracted and processed in the model in May, and that would give us a 3-month lead time, which is the lead time of interest to the Ministry of Health. But for implementing this kind of framework, we've come across several challenges. So one of them is translating disease outbreak probabilities into action. So currently the Barbados Meteorological Services produce several different warnings for different hazards, for example, dust haze forecasts, and they use a similar framework of providing a probability of a particular category, and that is accompanied by warnings about action that should be taken depending on the level of confidence of the forecast and the risk level of the weather event impact. And this is something we want to work on with our partners in Barbados to understand how we could translate this into action. And the second challenge is a lack of technical expertise, capacity and financial resources to really implement this for it to be operational, and who is in charge of developing this kind of information. So there is technical capacity within the Barbados Meteorological Service to run these different climate services, but there's no mandate to run this for health. And in the Ministry of Health and Wellness, there's interest to provide this sort of information, but there isn't necessarily the technical expertise to run this in R or to produce it on a routine monthly basis and to process that meteorological data. So we're really finding a big gap here is to do with training and retaining professionals and experts who can actually work between the climate and health sectors locally to sustain and implement this sort of climate service for health. If you'd like to read more about this, there are 2 articles listed here, and I'm happy to take any questions. Thank you.
Good morning, everyone. Today, I'll be talking about climate challenges, catalyzing health adaptation in India. The Global Climate Risk Index 2021 has ranked India as the 7th most affected country by devastating impact of climate change. Climate change adversely affects human health by increasing exposure and vulnerability to climate-related stresses and decreasing capacity of human systems. The 5th assessment report of the International Panel on Climate Change concluded that climate-related extremes will lead to a greater risk of disruption of food production, morbidity and mortality, damage to infrastructure, consequences of mental health, and human well-being. The major climate-related health impacts in India include vector-borne and waterborne diseases, effects of heat wave, and impacts of floods and droughts, which could lead to food insecurity. Heat waves in India continue to affect states of Andhra Pradesh, Telangana, Orissa, Gujarat, Rajasthan, Madhya Pradesh, and other parts of central India. Cyclones have impacted the eastern coastline of the country, the worst affected being Puri, Chennai, Nellore, Ganjam, Cuttack, and East Godavari. Underweight also puts population at an additional disadvantage. 4 out of 10 children in India are not meeting their full human potential because of chronic undernutrition or stunting. 6 out of 10 children are anemic. Priority states continue to be Bihar, Chhattisgarh, Jharkhand, Madhya Pradesh, Uttar Pradesh, which have significantly larger proportion of undernourished children below the age of 5 years. Amongst the vector-borne diseases, such as malaria, continues to threaten several parts of the country. 58% of malaria cases in the Southeast Asia region are from India. The endemic states include Orissa, Meghalaya, Chhattisgarh, Mizoram. The year 2020 also witnessed various climate-related episodes of cyclones, floods, forest fires, besides the COVID-19 pandemic. To address these climate challenges, the experts and researchers from various disciplines have created a consortium called CUGH. CUGH stands for Understanding Climate and Health Associations in India. This initiative includes academicians and researchers from several premier institutions across the country, including All India Institute of Medical Sciences, National Institute of Malaria Research, TERI, Taru Leading Edge, to name a few. A website has been initiated to generate awareness and sensitize different decision makers and administrators. Various knowledge products have been created on linkages of climate challenges and health, vector-borne diseases, impacts of heat waves. Tools such as to assess vulnerability have been developed to help generate ranking of human vulnerability across the country, to prioritize action and for resource allocation. There is a need for generating evidence to link to action which encounters 2 major challenges, that is timeliness and involvement of policymakers at different stages of evidence-based research. However, several implementation challenges continue to be faced. Efforts are needed, not just for sensitizing decision makers and the health community. There is a need for building of matrices for measuring health impacts, need for funding support, need for convergence across sectors, for building resilience of the population. Thus, there is a need for action coalitions and building of pilot projects across the country to convert science-based knowledge into action, which strengthens the health systems. Many thanks for your support.
I'm the Dean of the Graduate School of Public Health. Greetings, I'm Maureen Lichtveld. I'm the Dean of the Graduate School of Public Health at the University of Pittsburgh. And today I'm joining the session talking about adaptation planning for climate and health in the Caribbean. The Caribbean Health Climatic Bulletin is almost a one-stop shop for health professionals to gain information so that they can make decisions about health interventions and how to manage healthcare systems, particularly for climate variability. It's a tool that comes out quarterly and it's supported by CARFA, PAHO, and CIMH. One of the aspects of the climatic bulletin is to focus on specific diseases. For example, on respiratory illness, where in this case, less frequent episodes of Saharan dust incursions may reduce the risk or exacerbation of allergic rhinitis and asthma. On the other side, increased humidity in the coastal Guianas may increase the growth of mold and therefore attack and impact asthma. And so in addition to respiratory illness, there are gastrointestinal and vector-borne illnesses, information about those, as well as mental health, non-communicable diseases, and increasingly now COVID-19 and climate impacts. Two case studies. The first is adaptation planning in Dominica. The country of Dominica put together a national resilience development strategy that takes the country to 2030. The development strategy is guided by 5 Ps: people first, and then partnerships, peace, planet, and prosperity. One very important aspect of adaptation planning are Dominica's smart hospitals, where the hospitals are built to resist disaster events, but also to be able to provide services under emergency conditions by using resources more efficiently, but also at the same time reducing the environmental footprint. The PAHO Smart Hospital Toolkit is one that is being used by the country, particularly focusing on the Hospital Safety Index, a baseline assessment, and the Green Checklist. The second case study has to do with flooding in the Amazon rainforest of Suriname, where in 2006, 31,700 people were displaced. They had to relocate their agricultural fields higher up away from the river to less fertile areas. The adaptation there impacted nutrition, it impacted income, as well as health ultimately. The impact on income is particularly tragic because they're using mercury to do gold mining, resulting in contamination of the soil, the rivers, the fish, consumption of contaminated fish by pregnant women, and the impact on kids, and particularly neurodevelopment. And so these two case studies tell us that there are some correct ways and some beneficial ways to do adaptation planning. And there are also ways that could be detrimental to health. Therefore, it is really urgent to examine factors that influence sustained community resilience, particularly in the context of increased frequency and intensity of climate variability, including floods. I want to acknowledge my colleagues, Dr. Firoz Abdul Wahid and Dr. Hannah Covert, and want to acknowledge our funding source, IREP. Thank you.
Well, thank you, Tricia, for that wonderful series of case studies, flawlessly presented, and a huge thank you to all of the teams that went together to make those. There's a comment in the chat about how can we see them again, because they're all going so quickly, and I share that feeling. If all of the folks who are on our webinar now from the case study want to turn on their videos so everybody can see you, that will be great. Bill, you kind of hung out a very easy question. I'm going to hold off on that for a second. I'm not going to ask you about your acronym, but ask a question that everybody can partake in. One theme that arose, and it was wonderful to have examples from Asia, Africa, and the Americas. But one theme is this issue about acceptance and uptake in a setting of uncertainty. And so for, especially a lot of the early warning systems, we see some variability in the predictive value of the early warning systems. Bill showed the system which is way above a lot of what we've seen at 90% sensitivity specificity. Rachel was showing, some more incremental improvements, adding the meteorologic literature, and Michael, you've been developing this for many years and honing it. So my question to anybody who wants to take this on is, if you have any thoughts about ways that you have, so the implementation practice, ways that you have addressed what I hear about, which is, health departments being skeptical and being afraid to act on something because they don't trust it. It's different, it's new, and sometimes it's not 100. Nothing's 100%, but it's not 100%. So the double question of how have you worked through the uncertainty with some of the public health stakeholders or community stakeholders, and secondarily, what ideas might you have for embedded research or implementation science research to help us grapple with this, especially climate change, as we think about longer term predictions, there's more uncertainty. So I hope that question is clear.
John, I can take a first shot unless Michael, you want to go?
Go for it.
Things that we've done to I guess, reduce anxiety by stakeholders who would use the data. We have repeatedly done tests with them. So live testing with folks at CDC Peru, as well as in different parts of the Ministry of Health. We've done that several different times, and I don't think we're at the point right now that they do not believe that our system is accurate and useful. The point that we were at, other than the turnover, is just the fact that the health system itself is so overburdened at every single level that in order to transfer technology, they don't have the extra bodies to actually take it on. And that's something that we thought we'd be able to work through, but that was probably a poor assumption on our part. And we're learning that the ability to kind of take on new technology in a government health ministry is not only just challenging, it requires a full commitment from I would say, especially in a decentralized system like Peru, Ecuador, or Brazil, you need support at all levels. And, for our experience in Peru, because of the turnover that occurs, we don't always get that. But I don't think that anybody that we've talked with in Peru was not convinced that our system could not be useful and be used. It was more of an ability to actually figure out how to adopt it. And I think that's something that we took on as a new strategy, which is what I mentioned in the talk. Going through this implementation of the technology outside of government, which takes that responsibility off their hands.
Thank you.
Yeah, I can jump in and add a few thoughts. I mean, one is that, and these are things that have come out of my discussions with public health experts and decision makers over the years. One is that we're already predicting things. In Africa, there are, everyone is using some type of early outbreak detection algorithm, even if it's, like the very simple WHO threshold approach. So, people are already trying to do this. And even when we make assumptions like next year is going to be, well, it'll probably be about the same as this year, or I assume that there's, an even malaria risk across all of these zones or regions. Those are predictions. They're just predictions made on, a very straightforward, simple baseline model. So, my sense is that the decision makers are not necessarily, they're not, at least the ones I've worked with in Ethiopia, having new predictions coming into the mix. I think a couple of things. One is that, and I think this is kind of along the lines with some of what Bill said, is you have to just do it and kind of get them used to, get people accustomed to seeing the predictions, looking at the outcomes, and kind of understanding how it all works. It's kind of like the way that we interact with weather forecasts. We're not, when we look at the weather forecast on our phone, we're not checking the underlying accuracy statistics or, looking at the confidence interval. But because we do it all the time, we have kind of an innate understanding of how good it is, what we can do with it, how accuracy decays going out into the future. And then I guess one last point is that again, the feedback that I've gotten from my partners is they want to make the decisions and they want as much information as they can get. So, one of the early things that I got back from my stakeholders was, okay, we want, the alerts are great, but we want to see more than the alerts. We want to see it in the context of, what have the historical case trends been? What are the underlying climate anomalies? What's happening now? So they want to look at it in a very information-rich context. And then ultimately, bring that, and also because ultimately they're not going to base everything they do on a climate-based early warning system. They're like, okay, if we can understand this and get the right information in the right format, we can bring it into our decision stream and it can be very useful.
Great. Thank you, Mike. Do we have anybody else who wants to address issues related to uncertainty? Okay. We had another question that came up that I was thinking would also be a good discussion question in our next section, where we'll have Virginia Murray, who is one of the world's experts on disaster risk reduction. But Bill has taken the initiative to answer this question. I'll open it up to everybody because it's an interesting question, and it gets to this intersection of disaster research response, which is a program NIEHS and NIH are engaged in, and implementation science. So the question is, what kind of skills do researchers need in order to be able to conduct these kinds of studies to understand barriers to implementation in a setting of an actual disrupted community, a disrupted region from climate change impacts or a weather-related disaster. And how is conducting research in those settings different from working in more stable settings?
Hi there. I'm unable to turn on my video, so I need permission from the host, but otherwise I'll just go ahead and try and
Sorry, Rachel, keep trying. That's been something, if you, we all kind of experience that. It's a weird thing, but turn it on, off, look at your settings, and somehow it often will just show up that you can do it. But please go ahead and answer the question too.
Oh, maybe, look, there we go. Thank you. It worked. So yeah, I guess some of the skill, just thinking about the different examples we've worked in, I think skills in data science is a big one, being able to process different like multi-source data sets like epidemiological data, also weather station data, being able to combine GIS with some sort of data management software like R, sort of being able to combine those different layers to sort of visualize risk. And also I think in some disaster settings, machine learning techniques are becoming really important to be able to sort of use satellite imagery to understand where your sort of your disaster hotspots might be. And yeah, so I think we're seeing like quite a big gap in sort of GIS, open source software like R, and sort of machine learning and statistical processing techniques.
Great, thank you. Thank you very much. Did anybody else want to address a question like that either?
Can I just add on to this? I wrote this in the chat, but I completely agree with what Rachel said. The other set of skills that I think are critical, especially in disaster management and even in early warning systems that we work in, are the soft diplomacy skills that are needed to foster relationships. When we added a person who was an expert in diplomacy a couple of years ago, it really changed the way we were able to interact with different folks in the Ministry of Health and the Ministry of Environment. And I can't say enough about that skill in terms of diplomacy that really helps, I would say, elevate the technical science side.
Great, thank you both. I am not seeing another question in the chat, and having deprived everybody of a sufficient break the first time, I'm going to try to offer that back, and we can end the session now at about 12 o'clock Central, 1 o'clock Eastern. We will take a 10-minute break, and then we'll go into a panel discussion. We're going to hear first just a few comments from Virginia Murray, who has, as I mentioned, one of the world's leaders in disaster risk management, disaster risk reduction, and this intersection of implementation science and disaster risk management. And then we will have a full panel to discuss a lot of the questions that we have now. And then after a little bit of a moderated discussion, we'll open it up again and invite all of our speakers and panelists and case study folks into the final open discussion. So thank you. Those were amazing case studies. We're getting a lot of comments in the chat saying, how do we see that again? It was so fast. It was so much. So thank you for that. Everybody will be able to see a recording of this. With that, Tricia, any other housekeeping items, or just we'll see everybody back at about 10 after the hour? Okay, whichever hour it may be for you. We'll see you back in about 10 minutes. Welcome back, everybody. I hope that was a good break for you all. Tricia, if you want to show that slide again, that would be fine. We have had a really rich first couple of hours, and I am very excited about what is going to be a very, very rich third hour as well. So we've had our opening lectures, we've had really wonderful case studies and discussion, and now we're going to open things up a little bit more with an expert panel. We're going to start by having brief comments from Dr. Virginia Murray with Public Health England, who will, we have asked to bring in the issues related to disaster risk reduction implementation science as a kind of a kickoff to this panel discussion. And then we'll have a facilitated discussion with our experts, Dr. Lindsay Martin from the National Institute of Environmental Health Sciences, Dr. Anna Stewart-Ibarra from the Inter-American Institute for Global Change Research, and Dr. Sadie Ryan from the University of Florida. And then for the last 15 to 20 minutes, we will open it up and invite all of our speakers and panelists to join and really open it up to all of your questions and answers too. So at any point, feel free to start putting questions and answers into the chat. But with this, or with that rather, let me just ask Dr. Murray. Dr. Murray is the head of Global Disaster Risk Reduction for Public Health England since April 2014. And this year she has added to her responsibilities, not just disaster risk reduction, but serving as a senior public health advisor for COVID-19 as well. And Dr. Murray is asked to share a few slides, so I'll turn it over to you. Feel free to share your screen, and we'll have just brief comments from Dr. Murray, and then we'll introduce the other panelists. So thank you.
A huge honor to join this call. Whether it's going to work or not, I have no idea, but let's try.
That looks great.
Have you got the full screen? Have you got just my slides or all? Yes, you're there. So first of all, John, what a privilege it is to join such a fascinating session. It really is amazing, and I'm so grateful to you all. And it really is something that I've so much enjoyed, and hearing so many of my very good friends getting engaged. The idea of closing the gap between knowledge and practice is really key, and implementation science, with that fantastic discussions we had earlier on the priorities for health adaptation and climate change, are absolutely at the heart of what we need to do for disaster risk reduction. In my world, floods in the UK have been extremely common and have been going on for years. But it was our 2003 heat wave which caused so much harm for so many that caused us such distress. But we've had increasing numbers of wildfires in the UK, but also across the world. And of course, increasingly we're getting very complex windstorms, and we've had quite a few recently. But even in the UK, we get droughts. But we've heard so much of the discussion that droughts are an issue across the Caribbean and elsewhere already today. And vulnerabilities, of course, are key. Now, all these images come from a report that I did and contributed to in a small way that Chris Ebi led so much on, which was the IPC special report on managing the risks of extreme events and disasters to advance climate change adaptation that was published in 2012. So having been one of the contributing authors in this report, I went back to the UK and said, we have to do something. We have to change how we work. We have to set up an extreme events and health protection division inside Public Health England, or the health protection agencies it was then, because they change public health all the time in the UK. And we set this up. So I showed, because of that incredible work that Chris and others led, that we had to change science and how we worked. And we introduced not only the heatwave plan that we'd been doing before, but cold weather, floods, droughts, wildfires, and many other plans, review of windstorms, and all the other things that were so important to us and remain so even now. But it also drove another piece of implementation science, which, Chris, I thank you for yet again. We managed to influence the Sendai framework for disaster risk reduction, which links closely to the Paris Agreement and the Sustainable Development Goals. These incredible highlights of the United Nations that came through in 2015, which were adopted by all the UN member states, including the US, for which I am so grateful to President Biden for joining again the Climate Change Agreement. I really thank you all, because it's so important for us. But what is so interesting, that the timeline to deliver these was incredibly short. And we really only understood these things very recently. And if you think about the international health regulations that have been so key recently, it has been that driver of what we've been doing to help us to understand COVID. So let's think about these issues under the influence of COVID. This is yesterday's image of the world and how many people have been affected by COVID. It is enormous, and the World Health Organization has been running an incredible network of evidence to inform by counting the numbers, the surveillance, the systems in place to understand COVID-19. But in the UK, one of the things we've been doing is trying to vaccinate the whole of our population, and we are hitting our targets. But we want to vaccinate everyone and will only be as safe as the whole world being vaccinated. But to do a lot of the implementation science, we've had to understand what hazards are. And we've been working across the United Nations, but particularly with the Office for Disaster Risk Reduction, to understand hazard definitions, classification and review with the International Science Council, which under UN ECOSOC is the global voice for science. So it's this incredible network of colleagues that I've had the great privilege to chair. And we'll be launching our hazard information profiles, we hope in April, which will reflect the 302 hazards we've identified, which include nearly everyone that you've talked about, including haze. But to do this, we also know that we have to move a step forward. We have to work with the World Health Organization to produce a health emergency and disaster risk management framework, which includes all the hazards, but also includes the fact that we need to involve climate change, disaster risk reduction, humanitarian reform, sustainable development, as well as emergency and disaster risk management and response. And we've also built the guidance notes, which are incredibly important, which the World Health Organization published in November last year for proper reporting of these hazards. But John picked out, when I was speaking to him last night, the idea that the work we've been doing on the WHO guidance on research methods for health emergency and disaster risk management is critical. So let me show you a little bit about this. This is something we published in October last year with 164 authors from over 30 countries and all the regional offices of the World Health Organization involved. Absolutely critical. And this covers an introduction, identifying and understanding the problem, determining the scope of your study, study design, special topics that demonstrate the benefits, but also something that just came up in the last set of questions that I heard, John. How to become a researcher. What skills do you need? How are you going to do it? But let me take to the thoughts about closing the gap between knowledge and practice and the implementation science priorities for health adaptation for climate change. We do not have a perfect solution, I don't think yet. So this call is so important. But I wanted to introduce you to something that I think is really important, the International Network for Government of Science Advice, for which I'm a member, where we're trying to inform all the information that we have, how we build the evidence, how we reduce those 17 years of knowledge to outcome and implementation to getting it much faster through for all the different problems we face. There are a huge number of networks that I just show you here, including the UK government. We have a What Works network. What works, but also what does not work. And that's been really influential in how we spend our public money. But we go through to things like Cochrane Library, the UNDRR, Prevention Web, Conservation Evidence, Evidence Aid, the Campbell Collaboration. We're about to launch a knowledge hub under the WHO Health Emergency and Disaster Risk Management Research Network, which I'm really excited about. And we have a paper coming out soon on that. But the one thing you all talked about was the idea of multi-hazard early warning. The Sendai framework officially calls for it and has been adopted by the UN member states, each one of them. The call for substantially increasing the availability of and access to multi-hazard early warning systems and disaster risk information assessments to all the people of the world, I hope, by 2030. Let's get that target under our belt with the help of these calls, John. And finally, of course, we have the COP coming later this year in Glasgow, where we hope the Conference of the Parties will be working on climate change to try and see what we can do and deliver more. And that was referred to by Elena earlier. Thank you so much for allowing me to share that. And I now return to the main call. And thank you again, John, for inviting me.
Wonderful, Virginia. Thank you so much for those perspectives. Absolutely fits in beautifully. And I had a response and it just left me, but I was going to say that you know, we have the case studies that are some of the country level and smaller scale early warning systems, but we now have also this joint office between the World Meteorological Office organization and the World Health Organization that is also taking on this issue of multi-hazard early warning systems, the research agenda for that, and the implementation of that on a global scale. So I think we have this, you know, we have the frameworks, we have the UN agencies lining up, in a very powerful and important way right now. And so that's the top down, and now it's building that bottom up that we have to do in order to make the change on the ground. So thank you for that. That was really a wonderful additional perspective, and also a very nice response to what you had heard so far. And so as I call in the other panelists, I'm going to ask them the same thing. Just to start with a very brief introduction of yourself, and then you can either share something from your work of a critical implementation challenge or solution, or if you'd like, as Virginia did, something that has struck you in the first 2 hours, and how you might respond to that. So welcoming wonderful panelists, Lindsay Martin from the National Institute of Environmental Health Sciences. Boy, I think I missed lunch. Dr. Ana Stewart-Ibarra from the IAI, the Inter-American Institute for Global Change Research, and Dr. Sadie Ryan from the University of Florida. Welcome, and let me have you introduce yourselves. Lindsay?
Oh, hello, everyone. Hi. Thank you, John, for the introduction. And so just a little bit of background about myself. I'm a medical anthropologist and an implementation scientist, and a lot of my work previously was using qualitative methods in the context of implementation science. So it was great when I was hearing some of these case studies and seeing the importance of having stakeholder feedback and adapting interventions to the context. And so really thinking more globally about how to more effectively integrate qualitative and quantitative methods in the context of implementation science for climate health adaptation interventions, and really just a lot around this idea of the importance of stakeholder engagement and how important that is, and how it's really rooted. Implementation has to be in conjunction with the communities that we're working with. And so those are just some broad comments that I have from some of the discussion this morning.
Anna?
Hi, John, did you say my name?
Yes, yes, please.
Okay, great. Hi, my name is Ana Stewart-Ibarra. I'm with the Inter-American Institute for Global Change Research. We are an intergovernmental organization representing 19 countries of the Americas, and I'm based in Uruguay. So just brief comments. As our colleagues already mentioned, the modeling science and early warning system science, I think, has moved much faster than the implementation science. So what I've been thinking about these days more and more is more on the side of partnerships in terms of how we develop, strengthen, and sustain partnerships across the climate, health, and other relevant sectors, and particularly now thinking about disaster risk reduction. Often these linkages don't exist. And so that's really, to me, the foundation for any work going forward. So we have to think about who to work with, when, where, and how, what are the ethical considerations, and how are we going to deal with power differences within those groups. And briefly, also, when we interviewed climate and health stakeholders in the Caribbean to think about barriers and facilitators for implementing early warning system for climate sensitive diseases, one of the top things that came up again and again was that both the health sector and the climate sector did not have political mandates to work on these issues. And so without a political mandate, there was no clear institutional mechanism or pathway by which they could allocate people, resources, or work plans to further these efforts. And so to me, that was a clear starting point to be able to develop data sharing protocols, joint work plans, sort of the basic foundation again, and how implementation science can support those efforts, to me, is a question that I'm sort of mulling over. Thank you.
Great, thank you so much, Anna. And Sadie.
Hi, I'm Sadie Ryan. I'm a medical geographer at the University of Florida, and I'm currently the co-director of our Climate Institute here as well. And so I'm sort of really delving into issues of climate health, and Florida is probably a super fascinating place to be doing this, particularly in the realm of climate equity. We're not talking about that as much today, but that sort of equity lens really intersects with this question of these sort of co-occurring vulnerabilities and how climate is exacerbating some of those sort of distributions of vulnerabilities. And so as someone who was trained as an ecologist, and I'm a disease ecologist who became a geographer because the sort of concept of showing people maps of the phenomenon really struck me as this very powerful communication tool, but it also doesn't necessarily communicate the quality of data used in maps. And so this is always this tension of sort of how do we communicate with stakeholders, and do our models at the scales we're operating meet the questions that can actually answer stakeholder decision making. And so that's sort of stuff I struggle with. But in the context of this panel, it's really interesting for me to be the person who is on the sort of the research side of that research implementation gap. And reflecting on some of the talks earlier, I thought it was very interesting to sort of consider myself very upstream in the process of implementation. As Dr. Nita pointed out, oftentimes the goal of research is often to get to the publication, and then how that publication information is then translated down into implementation is very rare. And so I sort of, sit in a world where our incentives are very different. And so trying to think about how we can bring some of the training of stakeholder engagement back into the forefront in the development of projects in the academy to sort of mutually reach our goals is really important to help bridge that gap. I'll pause there. I have quite a lot more to say about that. I've been taking notes throughout all the other talks. So I just want to say thank you for doing this. It's really been incredible to hear these talks, and it's great to have these conversations. So I will stop for now.
Great. Thank you so much, Sadie. And Virginia, I'll ask you to turn your camera on and join us again. And we had a set of 5 questions, that we had lined up, and yet we've kind of talked about a lot of them. And you all have touched on one of the things that seems to have emerged, that we've talked about the implementation challenges at a very high level, the need for country buy-in, the need for the mandate to actually come to the health ministry and the climate ministry to work on this issue. And then the secondary mandate that they actually have to work together, which can actually be a challenge in and of itself. And then the bottom up, that we have to be co-designing research, co-designing the adaptation programs. And often that might mean building capacity or doing training of those stakeholders in order to be able to do that. That's a huge place to start. And we had that great early question about, how do we look at this through an equity lens? So I think what I'll do is just start off the conversation by asking you, we have covered a lot of the challenges that people are facing. We have covered some of the ways that we address those challenges. Let me just start by saying, is there anything that we've missed so far? Have any of you been thinking, well, we haven't quite talked about X, Y, or Z? Is there anything to kind of be comprehensive in our inventories? We had some great inventories of the challenges in some of the case studies as well. So I'll open it to anybody.
So could I bring up something that I think is really interesting? One of the things that we have been doing with the European Commission is their incredible mission on trying to look forward on how we can change things. And I think one of the very interesting ones that I'm fortunate enough to be a partner in, representing health in this community, there are only 15 of us, is the mission on climate change adaptation with societal transformation. So how do we get people in society to take forward what they want to do in a way that really makes a difference? For us in the UK, we were really excited that we reduced the number of plastic carrier bags that people use to go shopping with. It sounds trivial, but the effort that we went to was enormous. And then we hit COVID and they suddenly come back again because they deliver your food in plastic bags. But I get very upset about that. And I've been trying so hard to try and get people to realize that we don't need to do a lot of the things that we think are not good. And we really need society to push for this. And it's been quite an interesting issue. I don't know what you're doing in the States, but I'd love to know how you're taking this forward. How do you get the societies to get engaged to try and change what we need them to do for climate change adaptation, knowing that we have this incredibly short timeline that Chris and Elena and Daniel all talked about? Is there some way we can make a difference? John, what good practice do you have in North America that we haven't learned from?
Yeah,
yet.
well, Virginia, I know you've been out of commission briefly, but here in the United States, we've had some challenges, I think, with unity, primary adherence to scientific advice. It's been a tough time. It's been a tough time in the United States. It's been a tough time in the UK. It's been a tough time in Brazil. It's been a tough time in many places around the world. So, you know, I was very struck in your list, Virginia, of things going on in the UK. You've got a, you know, leadership in a network to give governments scientific advice. You know, I think that's a that's a nice model. You know, and the network about what works doesn't work. Yeah, no easy answers for that. But you're also raising, I think, you know, a very an important theme, and Chris kind of brought this up initially, that, you know, we're talking about adaptation, we're talking about public health protection, we're talking about resilience, but thinking about the implementation of changes or adjustments, it really does, it's really doesn't behoove us to do that in the absence of thinking about the sustainability side, the mitigation side, that these things, two things go together, that you know, you can't think about future adaptation, especially decades out, without thinking about what course are you on. And obviously we want to get on a course where we have to spend the less, suffer the least, have the least burden on our systems by mitigating the most. So there is that codependency, if you will, or you know, tight connection between the implementation on both sides, and health is, I think, a critical piece of both of this. But anyway, I'm not supposed to be talking so much. Let me turn it back to the panelists. Other thoughts?
John, I think I saw that Keith Martin had his hand up to comment as well.
So Keith, I am not exactly sure. Oh, maybe you have been promoted. Okay, now you are promoted. So let's hear from you. Thank you for joining us. Very honored to have you.
Well, thank you, Dr. Balbus, and big thanks to you and Tricia for organizing this. I'm Keith Martin, the Executive Director of CUGH. So, and I'm also a recovering politician, so I found this very interesting. I was a member of Parliament for 18 years, and you're getting to the actual crux of some really crucial issues. Small aside, the July issue last year of Foreign Affairs, if you can see this, I don't know if you can see my I think it all. There's a really good article there about climate change, and in essence, you know, the gap in my experience, what I found is that policymakers don't understand what we're producing in research. They don't understand the language. The products that are given to them are too large. I remember in my office, I'd receive a 2 or 3 inch document that said, "Here, Dr. Martin, we'd like you to do this and take this to the minister." I said, the minister's not going to look at this. Put it on 1 page or 2 page, put it in English, and then also align it with the incentives that they have. So you've got to understand the incentives that the politicians have. You've got to understand, what their objectives are, and you can often align what you want to do in terms of what their objectives are and their incentives are. And finally, we've got to bridge the gap with the politicians and also other sectors. And here in the United States, to answer, Dr. Murray, your one of your questions, there was a really interesting, the Keystone Pipeline discussion that took on. There was another discussion that didn't happen where a huge impact could have happened on climate change. And that was amongst those who are responsible for changing building codes. You change building codes in the United States and the impact on greenhouse gas emission reductions were way larger than whether the Keystone Pipeline was going through or not. So I just say this, that there's low-hanging fruit, there's things we can do, and at CUGH we're committed, as we do work with Dr. Balbus and Tricia and others, to work on the climate change areas, both here in the United States and internationally. So let's get on the advocacy work. Let's translate your great work into things that policymakers can use, and we're there to support you. So again, just really thank you so much for all of you for attending. John and Tricia, thank you for your wonderful work in putting this together. Over to you, John.
Thank you so much, Keith, Dr. Martin, and thank you for joining us and sharing your wisdom and experience. So we'll open it back up. We intended this to be a little bit freeform and to, again, invite comments, questions from all of the attendees at this point, and we'll soon open it up to the other speakers and panelists. But Anna, Lindsay, and Sadie, any reactions or new thoughts?
I could
No, I
bounce.
think, oh, sorry, go ahead.
I can bounce off of something Dr. Martin just pointed out that clicked for me recently here in Florida, which is that oftentimes you'll have city commissioners who are elected from the community, and maybe they're a former realtor. What do they know about how the infrastructure of that city interfaces with climate health? Can we start to bring sort of education documents to that kind of level for implementation? And what do those even look like? How do we train research scientists to know what that kind of document should look like? And again, that's me thinking about sort of what are our training tracks in the academy that can actually get the translation out there and help with this sort of stakeholder interfacing at levels that implementation is kind of happening.
Great, thanks. Lindsay?
Stuck on mute there, I apologize. Yeah, I just put my comment in the chat box that just kind of going back to that point earlier about that importance of soft skills among researchers and how it's really learning to translate these evidence-based interventions into language that the policymakers can use. And so just trying to work on developing that skill set. So I can see multiple things really as the fields come together, as climate change comes together with implementation science, it's learning those skills to be able to communicate what we do. And I think that really does dovetail with stakeholder engagement. When we go and meet with communities, it's taking what can be a complex multi-level intervention and being able to translate that in a way, and that can help boost that adoption. And so it really helps kind of bridge that gap there.
And I'll just add also that coming from a regional science funding agency, sort of our responsibility is to design funding programs, calls for grants, and tailored training so that we can support, especially emerging scientists and policy practitioners to be able to do this, because these skills are not obvious. And so, for example, in the II's call for grants, we require transdisciplinary collaboration where the end users or policy practitioners, community members, whoever that is a part of the science process from day one through the implementation stage. And we require them to go through team training before they can receive grants. And we work with them together on developing the grants. And so that's been an effective strategy. And also that requires partnership across at least 3 countries in the region. Again, John, you had made mention previously of how do we support regional international collaborations. And I know that Belmont Forum is also using some similar approaches and strategies. So we may want to touch on that. So I think there's a lot that we can do and some good models that are out there that we can promote and across the region. And this is especially important, I think, for supporting our colleagues, scientists and policy practitioners in countries that have limited resources for science funding, especially in the Americas. I was really struck by the map, I believe, that Elena showed on funding for climate and health work. And there was almost nothing in the Americas and very little outside, in Latin America and the Caribbean. So there's a huge gap to address, and there are concrete actions that we can take to address that gap.
Thank you. So what we were just talking about, this idea of being able to speak to policymakers in language they understand their incentives with soft skills. I would react and say that's implementation practice. That's how do you do it? I'm going to single you out, Lindsay, and ask you within the kind of paradigms and frameworks and systems that have been developed of implementation science research. And this resonates with me because I actually have to do this later today. I have to write 5 sentences that hopefully will go to a place where it will affect some change and people will understand the intersection between health and climate change. And going back to Chris Eby's slide, I could do it out of my gut, and I'm going to have to. But wouldn't it be great if I had an evidence base to support the way that we implement those soft skills? So Lindsay, could you just maybe, and then others, comment on, how, do we, how might implementation science research make that more effective?
Thinking in terms of like the research side, I mean, going back to the need for building in qualitative methods when you're designing your implementation research studies, and it's having that qualitative component with the robust quantitative component and really integrating the two in there, because you have to have that stakeholder feedback in order to inform so you're always thinking of, like the point Gila made earlier, thinking of implementation even when you're still building that evidence base. And if you have that stakeholder engagement, you use qualitative methods, you integrate the qualitative methods in with the quantitative data collection to tell that whole story. And so I'm an anthropologist, I think, in that holistic mindset. And so that's what can really help us when designing effective interventions and building that evidence base to make sure that it's really community informed, that it's addressing issues and concerns that the community has, and thinking downstream that looks at, you know, adoption, that you can help increase adoption of the evidence-based intervention if it's informed by that community input that you can get through the qualitative methods and the quantitative methods.
Thanks. And of course, that answer just got completely amplified and echoed in the chat box as you were talking. And, you know, it's making the case that we need to tell stories, but they're not fiction, right? Implementation science gives us stories that are nonfiction, that are real, that are grounded. Other thoughts?
Might I add a thought, John?
Please.
Lovely hearing all these comments and really useful. The experience that I've had of sitting on a UN science and technology advisory group for the Sendai framework delivery was that actually people want to know about science, but they want it to be really brief. They like the elevator pitch. We have to make the answer to the question to fit what they need, not what we want to tell. And it's got to be really brief, snappy, clear, but evidence informed. And trying to share that quickly is really important. So a lot of experience of talking to politicians and others. Keith, as you raised, is really to be not to ever present a tome, but to present something that's really brief. So we've used in a lot of the reports that we wrote for science for the United Nations Office for Disaster Risk Reduction, no more than 600 words, where we cite the problem, the science, the implication, the actions that were taken, and did it make a difference by government. So that was quite a useful way around to make it really brief and just to have a minimum of at least 5 effective and good peer review messages. So the strong message that we got was that the science had to be useful. Science had to be used. But most importantly, science had to be, so it had to be useful, usable, and used. So all those 3 steps were the steps that we had to make if we were really going to make a difference. And it was showing how science was used was really the bit that mattered with effective monitoring and evaluation. And that has always been the step that we've tried to drive for and to try and deliver on more effectively, using this concept of an elevator pitch, knowing that in emergencies, which is what we spend so much of our time, unfortunately, on at the moment, it's really got to be delivered really fast. We know that a lot of science is used by government. It uses for technical, regulatory. I loved your comment, Keith, or I think it was you, about the fact that building codes are so important. UNESCO leads on the building codes for the UN, and they have been really concerned that we try and do that better. And if you think about Florida and the risk of hurricanes, which always worries me, there's a lot of thinking about that. And of course, the insurance industry is there behind you a lot. So we have technical, regulatory, we have deliberative. So we're looking forward to what we might be doing. It's something that might not be urgent. We have informal, which is really the elevator pitch, and then the advice in emergencies. What I think about COVID has been so remarkable is that we've had over 100 peer review publications coming through in the peer review literature every day recently, and even more. And it's really hard to keep up with all of that. So we need systematic meta-analyses to try and understand what they mean. And certainly things like evidence aid have helped to do a lot of that type of analysis to try and make sure that it's much more accessible with just a bullet point on what they mean. And how they can be useful and used. And they've also translated into many languages, including Spanish and a lot of other languages. So it's trying to communicate in the language of need, but also at the time of need, and to be appropriate and to take on board what's changing around us all the time. And for us, the biggest thing that we've done in the UK has been really to build the science around the need for vaccinations and to get that now implemented. Even though, of course, we're now facing the variants, but we believe that we've covered that and we'll possibly revaccinate people again in the autumn. That's still being discussed. So it's trying to bring all of these things together to make sure that not only do the knowledge generators inform the knowledge synthesizers to the knowledge brokers. And I would regard the work that I've been doing in part as knowledge broking, as Chris Ebi has been doing, and as Elena is doing. But to hear the wonderful case studies that Michael and Rachel and others presented, in many ways, you are the synthesizers of the knowledge, using the generation of that knowledge, and how we can go through those different steps that we build the pathway to deliver something that will make a difference when we have to get on and get health, adaptation and climate change at the heart of what we need to do once we're through this COVID drama. Is that a thought?
Many, and many rich ones. Thank you very much, Virginia. We have questions coming through in our Q&A now, and I will encourage anybody who has a question to put it in the Q&A rather than the chat, which is also fairly active and a little harder to extract questions from. Did anybody else have a comment? There's been a lot of thoughts raised, back and forth between the implementation practice and the implementation science research. Other thoughts, reactions, comments? And if not, I think at this point, I'm just going to open up and invite anybody from earlier in the session to come and join us. And we can go through some of the questions that are coming through in the chat. And we have a couple of questions from Tom Mattei. And I'm gonna ask the second one. The first one we kind of asked in the case studies, which was about government leaders and constituents trusting models, trusting the outputs of models. We can come back to that. But Tom asked, another research translation challenge is the lack of in-government capacity to implement technically complex data collection, assimilation, and analysis. One implementation model is formal academic government partnership, such as Imperial College managing the London Air Monitoring Network. Are any of the panelists aware of similar models? Could NIEHS support this sort of arrangement? And I don't, if we invite folks back, I'd love to hear from Meena and in India, who has some thoughts about this. And I would love to open this up. I think that the UK probably has some pretty capable people in the government in terms of managing technical, complicated information. We have one on our panel. But I'd like to broaden that question perhaps, to a more global and low and middle income country setting. And how can an organization like CUGH, how can the UN agencies, how can US academic agencies, how can, some of our programs at NIH, like the GeoHealth program, how do we do that kind of capacity building for being able to use, as you said, Virginia, not only does the science have to be usable, useful, and used, but you also have to have users there ready to accept it. So panelists first, any thoughts?
I'll make a quick comment, and if Elena was on, she would be best suited to respond to my comment as well. But I wanted to mention that many of us who are on this call have been working for more than a year with WHO and PAHO to develop an open access online course about climate information for the health sector to address exactly these capacity challenges that many of us have experienced when we work with partners, especially in the global south, but not just so. So just basics in terms of data management, handling who needs to sit at the table. All of this is being developed through a consortium, I would say, of scholars and practitioners, and hopefully that will be available in the coming year worldwide.
Thank you. Others? So Lindsay is placing items in the chat. And
Yeah.
I was going to actually ask you this very question. So I'm glad you placed that. Why don't you say a few things, and then I see Mina has her hand raised. And I'm sorry, I'm noting if attendees have their hand raised, we may be able to promote, but if in the meantime, it would be great if you would put your question into the Q&A if you have a question. So Lindsay?
Yeah, so I was thinking in terms of the funding opportunity announcements that Dr. Netta had mentioned earlier, and those types of mechanisms that have been developed by NIH could support these types of partnerships that were mentioned in the question. And so one of the key ingredients, so there's a fantastic article that was authored by Enola Proctor back in 2010 that talks about the 10 key ingredients, and I'll drop the link in the chat box in a minute, about how these ingredients are really successful or part of a successful implementation science research proposal. And so one of those is describing your engagement plan, and so how you're engaging your communities or other governmental or non-governmental organizations in your implementation research. And so those mechanisms, those program announcements that Dr. Netta discussed earlier could be one place to start if you're looking towards NIH funding in this area.
Great, thank you. Mina, would you like to share thoughts?
Thanks, John. With our experience in India and the discussion
And I'm
here.
sorry to interrupt, Mina, especially without your video, maybe introduce yourself just very briefly for people who may have missed the case study.
Okay. Hi,
there you are.
I'm Meena Sehgal. I'm working in India, and I've had some partnerships with NIH through John. So we've been fortunate of getting funding and support on vulnerability assessments. What we've learned is that if all our projects are done much in partnership with the government functionaries, whether it is developing a course or it would all be very, very helpful if we have more and more partnerships with the government. One is there are data gaps which exist, and those data gaps can be identified and they can be recognized by the government only if they are part and parcel of the process. And another was that if the policymakers at the end of it, because the partners usually are scientists like us or like-minded people, but the decision makers often are a other set of people, and they understand what is either politically of interest to the general public, or they have to prioritize with different multiple dimension of work that they have. So if they have actionable outputs of any tools or courses that we have, that may help them a lot more. And that's what I've experienced in India, working with different state governments and the central government. Okay.
Thank you.
I thought it was great that you brought up the fact that people are contending with multiple different aspects of what they manage. And that's actually come up a few times with work we've done in different places, where if you're talking about vector-borne diseases and you want to tell people there's risk of vector-borne disease, perhaps the tourist sector might not want you to be doing that month. And so compromising sort of how messaging gets out and how to mobilize resources for those different sectors is super important. And especially, if you can pair those different sectors, pair as in hand-in-hand pair, across the different, ministries that they may sit in, and have them actually think about this process together, you can avoid some of those conflicts that might occur. And that's something that you really need to be sort of sitting with stakeholders and understanding organizational structures, which are not always immediately apparent when you start a project. And so I think, that goes back to some of Lindsay's points about really sort of at the very front end, thinking about who your stakeholders are and dealing with that engagement at the very beginning, and really listening to who they are also, sort of in cahoots with and dealing with in their shared resource environment.
Thank you. We have another question in the Q&A that I'm going to elevate, asking, are there any of the implementation science research teams, including behavioral scientists? And if so, are there resources or references showing the benefits of doing so? Specifically, issues like when to tell stories, how is useful defined? There, there's a big question. Useful for who? What type of behavioral approaches do diplomats add to implementation, et cetera? So the role of behavioral sciences in all this. I think lots of you can address that.
Yeah, I think, John, thinking that implementation science as a field is inherently transdisciplinary. I mean, that's the goal, to have that transdisciplinary approach. And so before I came to NIH, I was in the Department of Veterans Affairs. And when I worked on implementation science teams, I mean, we had clinical psychologists, I'm a medical anthropologist, you have your data scientists. And so you have to come together as a team. You have to bring your collective disciplines together. And so there is a lot of room, a lot of great examples. I think probably within the healthcare sector, clinical health, where you can see the integration of these research perspectives on these teams. But yeah, really, you have to have that transdisciplinary team to lift up these implementation projects.
Any additional comments or specific
So if I could
anecdotes?
Can I pick up from that,
Sure.
John? To us, behavioral scientists are really key. We have a group under our Government Office for Science. Yes, we have a Government Office for Science where we have a chief scientific advisor, which I think has been incredible in COVID, but actually we've had one for many years, really since the 60s. But we have a group called Scientific Advisory Group in Emergencies, known as SAGE. We always hope that they will be SAGE, but that's what they're called, which we all rather like. But we now have a behavioral science group that has been absolutely critical to see how people will work with lockdown, how people will cooperate with our guidance and advice, how people will cope with vaccinations. And we have a wonderful behavioral scientist team that we work with incredibly closely in our public health advice, guidance and expertise group to try and make sure we reflect the knowledge and the learning from all the different research programs we've been engaged in to try and make sure that we influence usefully the guidance that could be given to people in a way that's accessible and understandable, and how we bring in easy read versions and versions in different languages and try to make it much more applicable for the people who might need it, to try and make sure it's easy and it's not just sophisticated, but it's actually what people need to know in a way that they can access it. To us, behavioral scientists have really made a sea change. And of course, with societal transformation like Greta Thunberg wants, then we need to use them more. They're a great team.
Sounds like a wonderful model. We are running out of time. Anna, did I see you raise your hand? Did you want to make a comment? Well, with that, if all right with everyone, this has been really a phenomenal 3 hours. I think I have learned so much. I think we've had amazing discussions. I want to close with just a few thoughts. One, there was a question that came up about, the research funding. Lindsay has talked about the existing implementation science. I would encourage folks to be aware of the existing opportunities that are available. I would also give a heads up that there will be opportunities. We'll be making more and more opportunities, I hope in the near future, for the academic community to provide input to NIH on climate change and health and global health. So keep an eye out for those kinds of opportunities. Anna and I Anna mentioned the Belmont Forum, and that is a process that is underway. We are scoping the second collaborative research action under the Belmont Forum. The Belmont Forum, like IAI, requires at least 3 countries to be involved, investigators from 3 countries, and it needs to be transdisciplinary, and it needs to include the social sciences. I think that there's a lot of potential for the Belmont Forum to take on some of these implementation science challenges and to really facilitate cross-cultural comparisons, which could be very powerful. We're also working on an East Asia joint research program potential call in this area. So please do stay engaged. Please do share ideas. Look for these opportunities. And with that, I'm not muted, so I'm going to make some noise in front of my microphone here, because That was really fabulous, fabulous participation from everybody. I want to thank all who have stayed with us and have been in attendance. Huge thanks to our speakers, panelists, all the work that went into preparing those case studies. This, I hope, will be something that people will go back to and watch again. Huge thanks to Tricia Castranio for the incredible yeoman's work making this all happen. And a huge thanks to our CUGH team and the tech support. And with that, we will close and look forward to future collaboration in this space.
Thank you.
Thank you.
Thanks, everybody.
A lot.